Hello, my name is Rene Nakeda, and I am an epidemiologist at the Fairfax County Health Department. I'm here to talk to you about our poster, Household Characteristics Associated with an Increased Risk of COVID-19 Infection Among Hispanic Residents of Fairfax County, Virginia. So what we did is that we noticed early in the pandemic that there was a disparate impact of COVID-19 in our community as it pertained to Hispanic versus non-Hispanic residents, particularly between Hispanic and non-Hispanic white residents. So overall, through the pandemic, the relative risk of acquiring COVID-19 based on our confirmed case counts has been 3.0, but at the very height of the first wave of the pandemic, it was 16.8, and I'm going to show you here. In this graph, we have the age-adjusted rates of COVID-19, and you can see that in the first wave, the difference between the red line and the black line, which is the black line being the white residents and the red line being the Hispanic residents, was quite high. So that first wave was really driven a lot by Hispanic residents in the community, and many of them lived in overcrowded settings. They lived in multi-generational households. They do work outside of the home, work that they cannot stay home from. They were not shut down because they're in construction, they're in services, essential services, etc. For the second wave, it was a little bit different, right? You can see there towards the right that the white residents and the African American residents, Asian Pacific Islanders, Hispanics, everybody kind of experienced it. There was still a disparity, but everybody went up kind of the same slopes there, going up and coming back down. But you can see that in the first wave, it was quite pronounced back in the spring of last year, where Hispanic residents were really affected much differently. So one of the things that we did is that we did community testing events, CTEs, from June to December of last year, and we targeted Hispanic and other communities that were at higher risk for infection. So what we did then is that we made these maps, these heat maps, using kernel density estimation, and we found out where the most cases were by race and ethnicity, and we saw that many of them, like you see in the age-adjusted rates, many of them were Hispanic. And so what we did is that we did community testing events at these locations to try to get a better feel for what was going on, and we had them throughout the county, throughout the health district, but they were targeted there. And in doing these community testing events, one of the things that we did is that we asked questions about the household size, the number of people in the household, the number of people who were symptomatic, if the person getting tested was a contact of a case, if they worked outside of the home. And we collected all this information and did a logistic regression. So as you can see here in the results of the logistic regression, the significant odds ratios were median age by household. So the higher the median age, the more protected it was actually than the least likely that the person was to test positive. If the household was primarily Hispanic, there was an increase in odds of testing positive. If the household increased by one person, the odds increased by 11%. If the person was symptomatic at the time that they were tested, their odds of testing positive were very high. That is to be expected, right? If they were the contact of a case, 2.4 higher odds than if they were not. All controlling for all the other factors. Interestingly enough, if they worked outside the home, they were much less likely, as far as odds go, to test positive. But that one has a p-value that is not statistically significant. But we included it just because we wanted to account for it in the model, the final model. Obviously, we took it out. And so you have here some of our results. On the left-hand side, we have some pictures of the testing events, the staff setting up for the testing, people walking up. Our laboratory is right there in that fire truck. That's where we were doing the rapid PCRs, but also just processing the samples to bring them over to the lab for testing by PCR. You see our staff ready to take on folks to test them. So as you can see, we also have some information here on the participants by race and ethnicity, non-Hispanic whites, Hispanics, so non-Hispanic white 15%, Hispanic residents 55%, Black or African American 15%, Asian Pacific Islander about 9%, other or unknown 6%. And then participants by work status, exposure status, and symptom status. As you can see, we have here the number of participants. Negative is the dark blue, positive is the green. So many people tested negative, but quite a few number tested positive. As you can see here, if they had contact with a positive case, they had a little bit more of a chance of testing positive, and that's to be expected. So you can see in our poster the results. We tested about 3,500 individuals living in about 2,400 households. We found that Hispanic households, larger households with a symptomatic member, and households with a contact case had higher odds of at least one member testing positive for COVID-19. Controlling for age alone, Hispanic households had a significant higher odds of at least one household member testing positive compared to households without Hispanic members. Controlling additionally for household size, symptoms status, contact with a case, and work status, Hispanic households had 83% increased odds of at least one member testing positive, with significant confidence intervals right there. So our conclusions in this is that, based on our logistic regression model, a person living in a household with 5 other people had a 67% higher probability, and we converted those odds to probabilities of testing positive than a person with a similar characteristic of living alone. So compared to somebody who lives alone, overcrowding, that seems to have driven this, at least for us here locally, that seems to have been driving much of the pandemic. However, having at least one symptomatic person in the household showed the greatest increased odds of testing positive, which kind of makes sense, right? If you have been exposed to somebody, you're more likely to test positive, but you're also more likely to be in a high occupancy place. And for this, the definition of overcrowding, by the way, is we go with the census, which is more than one person per room in a household. Public health's response, our recommendation, obviously, is that public health's response to COVID-19 should aim to address overcrowding and other social determinants of health associated with overcrowding. Of course, like any other observational study, any other study of any kind, we have limitations, and those included targeting specific locations to hold community testing events. So we weren't as widespread as we would have liked. That was just logistics. That was just what we were aiming to do with this CTEs. We were kind of expecting folks from other parts of the health district to go get tested on their own, but we targeted the area where we saw some hesitancy to get tested, but we also saw an increased burden of the disease. Inability to know the exact characteristics of the household members not present at the testing event. So when we were surveying the folks that were getting tested, we were not asking them specific questions about the people not there. So it would have been great to know who wasn't there to get tested and what were their characteristics, so we could control for them as well. It was hard to know or verify the overcrowding status, so we were just going on how many people they were telling us lived in the household, but it was difficult to know how many rooms there were so that we could accurately define overcrowding. So we use census data as a proxy at the census tract level to kind of confirm, we're seeing a lot of overcrowding from this census block, and we went to the census data and kind of confirmed that that is a census block that has some significant overcrowding reported in the American Community Survey. And of course, there's things out there, right, that are not identified that could be influencing our findings. So, hopefully in the future we can do a better job of ascertaining all those. Finally, some acknowledgments. We want to thank all the staff and volunteers who work tirelessly to provide testing opportunities to high-risk communities and to the community, obviously. People who participated in this, they were our data, but they're more than just data, right? They're people. And we want to thank them for doing their part to keep each other safe, getting tested, and then following the public health recommendations depending on their test results. So if you have any questions, I'm available. My contact information is on the site for this poster. We have some handouts there. We have the poster as a PDF if you want to download it as well. If you want to discuss any of this, more than happy to do so. Please feel free to contact me, and thank you so much for your time.